Hi, I'm Dr. Martha Mims. I'm Section Chief of Hematology and Oncology at Baylor College of Medicine. And joining me today is Dr. Sarvari Yellapragada.
Hi, good morning, everyone. I'm Sharv Yellapragada. I've been a fellow here at Baylor, so Dr. Mims has been a mentor to me all these years, and I'm Associate Professor of Medicine here at Baylor, and I work at the Michael E. DeBakey Medical Center. Dr. Mims, when you first introduced this topic to me of looking at comorbidities and racial disparities in patients who have either monoclonal gammopathies or multiple myeloma, I really didn't think I would find that much. I was just surprised by the amount of disparity, even in comorbidities, not just access to care. Did you know, Dr. Mims, that this is what we'd find? Had you already some background knowledge on the topic?
Sharv, I would say that having been part of this program, my eyes have been very open to how much we don't know and how much is out there that the average hematologist probably doesn't know. So I think it's really important to delve into this topic.
And that's why it gives me great privilege to bring this topic to our audience. The purpose of this podcast is to understand three specific areas of disparities. The first I focused on was to look at comorbidities that are particularly prevalent in African American patients, not just because it may impact their overall well-being, but also disease-specific outcomes. And I was surprised to learn quite a bit of impact that comorbidities make. The second thing I did kind of know about, but delved into a little bit more, was to understand drug-drug interactions and dosing considerations and specific medications, how they're handled differently in different ethnic groups. And then I did look into pharmacogenomics and treatment side effects. So without further ado, I just wanted to ask you, let's jump into obesity and diabetes, because I thought those were the two most impactful areas as relates to comorbidities and MGUS and myeloma. Have you seen in your practice how diabetes and obesity affects our patients?
I really hadn't thought so much about it until we went through preparation for these slides. And thinking back, I think there is a significant impact both with regard to obesity and diabetes, but I think it's hard to dissect out, and you really have to look at large groups of patients.
That's absolutely right. The first thing I learned was just looking at the disparities in the incidence of obesity nationwide. I also came across this really interesting article by the WHO, and the WHO citing obesity as one of the risk factors for 13 different types of cancers, and this included multiple myeloma. Now, in the NHANES study, about 48% of non-Hispanic African Americans have a BMI that is considered to be in the obese range, while that is only about 34.5% in non-Hispanic whites. So I just thought just the incidence of obesity was something that was so broadly different. And then I wanted to delve into how this pertained to the risk of myeloma. Now, again, based on the New England Journal study that was published in 2016 by Lord B. Secter and team, had shown that there's positive associations of BMI, not just being obese, but also overweight. So there was a 1.2 increased hazard risk for those who were overweight of having myeloma, and about a 1.5 for class 2 or 3 obesity. Isn't that a rather high hazard risk, Dr. Mims? Rather surprising for a modifiable risk factor, perhaps?
Well, I think there are any number of data for various cancers that suggest that obesity plays a role. And I think myeloma is somewhere in the middle in terms of, the role of obesity, but there certainly does seem to be a role.
Now, I wanted to dig deeper, and I wanted to try and understand, is it the risk of going from MGUS to MM? Or is it the risk of developing MGUS, which is the pre-malignant condition? And at least in my readings thus far, again, I'm learning more as we speak about this topic. It seemed to me like overweight or obese status is not associated with MGUS, but it's mainly a risk factor of progression from MGUS to myeloma. Again, I do want to delve deeper, but one thing I've really started counseling my patients with MGUS is to, of course, we should do this for everybody, but I've actually mentioned it that it's potentially a risk factor, and maybe that is a modifiable aspect of their health if they wanted to take things under control. So in a way, I think it empowers patients and providers maybe to address certain key modifiable risk factors in MGUS transmission. Do you think this is something we should incorporate into our daily practice?
I do. I also agree with you that we should be talking to all patients about this issue.
The next thing was diabetes, and I'd been interested in this topic for a while because I had noted some literature stating that metformin does change the pace of myeloma. Again, I just wanted to understand more about this, but I had heard about this prior to this podcast. Now, have you noticed the complications that diabetics face with myeloma, especially with steroid use?
I think steroids and also neuropathy. I think we have to be much more careful in our diabetic patients and the risk of neuropathy that comes with some of the medications we use.
Absolutely. So the first thing, just like the obesity related research I did, I was also looking into what is the disparities in the prevalence of diabetes. And just like obesity, our African American population does seem to have a higher prevalence of diabetes, not just the prevalence, but also its complications compared to white patients. Is this also something you had noted, Dr. Mims? I know you serve the underserved.
I think that most of the patients that I see have access to medical care. And so I think if most of them will access that medical care, they do have fairly good control of their diabetes, but I think there's a wider group of patients out there where that probably doesn't apply.
Absolutely. Now, the next thing I was trying to delve into is looking at the association with diabetes and hematological malignancies. So just like the New England Journal study and impact of obesity on monoclonal gammopathies, I did find an article in Diabetologica and a couple others actually that suggest that diabetes does have an impact on multiple hematological malignancies as regards to outcomes. Patients with diabetes tend to have a higher risk of developing hematological malignancies. This includes leukemia, lymphoma, as well as myeloma. Now, the hazard ratio wasn't quoted to be very high. It was about 1.15, but it still seemed a very interesting fact that just having diabetes could increase your risk of developing hematological malignancies. Do you have any thoughts on that, Dr. Mims?
Well, I think there's a lot we don't know about obesity, and obesity, as you know, is an epidemic in the U.S. And I do think there's an inflammatory component to obesity that we don't completely understand, and understanding that might help.
Absolutely. Now, the next topics I wanted to focus on was just looking at when you have patients with myeloma, how do racial disparities play an impact on their outcomes? So I came across a few abstracts and of course some publications, but across the board, all of them seem to suggest that African American patients with myeloma tend to have a higher comorbidity index, specifically the incidence of hypertension, nutritional deficiency anemias, like we mentioned, diabetes, but also pulmonary and renal issues underlying their presentation. So higher incidence of COPD, renal failure, other endocrinopathies other than diabetes, and also more cardiac complications. Dr. Mims, can you tell us about challenges we've had in treating patients with multiple comorbidities and myeloma?
Yeah, I think it's a very difficult, Shar, because you don't always know which ones of these comorbidities precede the diagnosis of myeloma and which ones follow. And so you have to be extremely careful and thoughtful about the other medications that you use with these patients, how delicate myeloma patients' kidneys are, and the other issues sort of surrounding care of the multiple myeloma patients that perhaps the primary care doctors might not be aware of. So one I think of is the use of NSAIDs. So I'm extremely careful about the use of NSAIDs in my patients with multiple myeloma, but I found that many of the primary care doctors might not be. So when I write my notes, I try to put in the note, be extremely careful about use of NSAIDs, and I try to also educate the patient about those things.
You're absolutely right. I do think having comorbidities impacts the myeloma, and having myeloma impacts the comorbidity, so it works both ways. The other thing I'm really concerned about is using loop diuretics in the early stages when the myeloma is not yet controlled. So you're absolutely right on that. The other thing I found was there was a study looking at myeloma patients enrolled in the Connect Multiple Myeloma Registry, and it showed that diabetes clearly seemed to have an impact on outcomes with shorter adjusted PFS, but notably in the subgroup of patients with diabetes, BMI, higher BMI specifically, seemed to have a shorter overall survival. So this study was kind of tying in the two things we spoke about earlier, both the impact of diabetes and obesity affecting patients and their outcomes with myeloma. I did want to talk to you a little bit about our work on looking at pharmacological disparities and how they might impact race. I believe this is an area of controversy, and I don't think there's one right answer to whether race should play a role in personalized medicine. My personal opinion is that it's very difficult to link race alone to making pharmacological decisions. I don't know what your thoughts are. Of course, I came across varying literature as I researched this topic.
So one example that we've talked about, Sharv, is the fact that African American men more frequently have G6PD deficiency. And I'm always mindful of that as I give particular drugs in African American men. And I think there are examples where genetic polymorphisms are closely tied to race, at least enough that we should, as clinicians, be aware and be thoughtful of those things. I do completely agree that genetic polymorphisms and race are two different things, but I do think there are examples where it's important to recognize the close link.
You're so right, Dr. Mims, because I did look into specifically polymorphisms rather than racial disparities. I looked at polymorphisms as it impacts to certain myeloma therapies. Now, we know that lenalidomide and pomalidomide don't have the same impact on every myeloma patient. And I was curious to see what kind of pharmacogenomic data exists to predict response. One thing I found is that germline cereblon polymorphisms may impact the efficacy of IMiDs. But again, in this study, the impact of race by itself was not clear. So as you mentioned, I think the polymorphisms is something that maybe down the road could be ready for prime time, but not quite yet. And rather than race, that is probably the bigger factor. The other thing I also looked at was looking at how to predict for peripheral neuropathy in bortezomib, because that certainly can be limiting in terms of continued exposure to the drug. And I did find some studies that suggest that tibial nerve polymorphisms are associated with higher neuropathy. Now, again, the conclusion of this study mainly suggested that the polymorphism may be a predictor for incidence of neuropathy, but the impact of race itself was not clear. Now, I tried to look at therapeutic response to another class of agents, the three big classes, IMiDs, proteasome inhibitors, and then the monoclonal antibodies. And again, I did not find that there was any therapeutic differences in response to monoclonal antibodies. So I didn't think, especially with the IMiDs, PIs, and monoclonal antibodies, that race alone made a big therapeutic impact in terms of decision making. What are your thoughts on this, Dr. Mims?
I have to say, in my own experience, I've not seen any difference in response to the monoclonal antibodies among my patients with different racial ethnic backgrounds. I haven't codified it, but I haven't noticed it either.
Yes, that's been my personal practice as well. Now, coming to the last segment of what I had looked into was related to supportive care medications. And you had mentioned G6PD deficiency, and certainly myeloma patients, especially if they present with renal failure, bulky disease, or high volume disease, are at risk for tumor lysis syndrome. And as we all know, rasburicase has a risk of precipitating G6PD hemolysis, and so that's something we should certainly be cautious about. I sense there is so much of mixed ethnicity in our population. It's probably worth checking G6PD for everyone who you're trying to give rasburicase to, was the conclusion of this study, before using rasburicase. So I've tried to incorporate that in my practice, though sometimes it's hard to get this test done in an emergency situation. Any thoughts on this, Dr. Mims?
I would agree. I think that it's difficult to get rapid turnaround on the test, and usually the drug needs to be used rapidly. So screening is not always something that's doable as you're giving the drug, but I think at least if you're going to give the drug, particularly to a man, that you need to have your antenna up and be careful.
Absolutely. The last couple of agents I looked into were bone modifying agents. And again, while I just want to emphasize that race alone shouldn't impact our decisions, I did come across some studies that suggest higher incidence of osteonecrosis of the jaw in white patients versus African American patients. But the conclusion stated that the sample size was quite small. They did come up with some single nucleotide polymorphisms which could potentially be associated with osteonecrosis of the jaw, and this risk allele was less frequent in the populations that did not develop ONJ. Now, the last one was actually allopurinol, which we often use to prophylax or even in later stages treat tumor lysis. And in this, again, there seemed to be a disparity in the HLA alleles that predispose to drug reactions with allopurinol. Again, while race alone shouldn't be a factor, I did learn that certain polymorphisms can predict for allopurinol related allergic reactions. Finally, a study that we did here at the VA where vitamin D deficiency, looking at veterans across the nation, when you had vitamin D deficiency, it seemed to predict poor overall survival in white patients, but not African American patients. Having said that, vitamin D deficiency should be looked for and treated across all myeloma patients, especially once their hypercalcemic phase has resolved, so that they can get bone strengthening over time. Dr. Mims, do you think we focus enough on bone health in our myeloma patients? Do you think we could do a better job there?
Oh, absolutely. I think we could do a better job, and I think that we should be looking at all of our patients and thinking about the use of bisphosphonates and repleting vitamin D in all of them.
Thank you, Dr. Mims. And so researching this topic together led me to draw a few conclusions. And I just wanted to share with our audience that comorbidities and self-identified race are linked to some extent to risk of MGUS progression, but definitely linked to worse outcomes in myeloma patients. So as I mentioned earlier, one thing I've incorporated more rigorously in my practice is to counsel MGUS patients about their weight loss, dietary habits, and control of their blood sugars, as well as maintaining a high level of activity to control their diabetes. Now, we know that there are disparities in occurrence of diabetes, which is the reason why there could be adverse outcomes, one of the reasons at least, why there could be adverse outcomes in patients with African American ethnicity. So I don't have much more to say on comorbidities, but Dr. Mims, I thought your comments on how each can feed into the other are very important. I don't know if you have any parting comments on comorbidities and race for our audience.
I think it's important to take into account comorbidities in all of our patients and the role those may play in progression of multiple myeloma and helping patients address those things if we can.
And as regards pharmacological differences, the second segment of our podcast, I believe that studies at this point at least argue against using race or ancestry for therapeutic decisions. However, having said that, as we both emphasize, there are single nucleotide polymorphisms that have been identified as predictors of efficacy with perhaps certain drugs, but also toxicity of certain myeloma therapies. Without being race as the main factor, these may be something we could use down the road. But overall, all therapies are tolerated well in African Americans, and the more important issue is probably timely diagnosis and access. Dr. Mims, do you have any thoughts on pharmacological differences?
I agree with you. I think the polymorphisms are the more important decision-making tool that we have. And I think it's important to know that some of the polymorphisms are more common in certain races, but certainly aren't confined to any one race. And so I think understanding those things is more important than any role race would play in decision-making.
Again, I'd like to thank you, Dr. Mims, for working together on this. I'd also like to thank ASH and the France Foundation for giving us this opportunity. And I hope the audience learned more about comorbidities as it impacts plasma cell neoplasms. Thank you all.